I'm David Elliott. I head the Heart Disease Group here at Murdoch Children's Research Institute, and I'm joined by my friend and colleague, oncologist and clinician scientist, Rachel Conyers. It's clear that clinical genomics has advanced a lot over the years, and one other area that's advanced a lot is oncology. So, Rachel, I'm wondering whether you could give us some sort of description of how oncology is advanced in the treatment of childhood cancers.
Yeah, sure, Dave. So, one thing that people not realise is where the word oncology comes from. It comes from the Greek word meaning burden, which is a really apt description of what it means both physically and psychologically to have a diagnosis of cancer. We've certainly come a long way over the last 30 years. Back in the 50s, childhood cancer was incurable until Dr. Sidney Farber discovered the first chemotherapy agent that we now use today. And luckily today, 85% of children that are diagnosed with cancer will ultimately survive their disease.
So I think when we started working together, Rachel, one of the things that I was worried about, and I wonder whether other parents express this concern to you, is the side effects of these chemicals. They're quite toxic, so I'm wondering what sort of things you see in the clinic.
Yeah, so certainly the first question that parents ask us is this diagnosis curable? And the next question they always ask is about what side effects their child will have. And although the survival rates are excellent, you and I both know that 5% of childhood cancer survivors will have significant health effects as a result of having had that treatment.
This is an illustration of sort of the burden that you talk about that families face. And on the left here you have my son James, and on the right you have his friend Connor. And you can see they're both quite healthy. They're chewing down on what is not dog biscuits. They're actually gingerbread men baked by James's grandparents. But Connor had to have chemotherapy, so he's 15 times more likely to develop heart failure, 8 times more likely to have cardiovascular disease, and 9 times more likely to have a stroke. I think it's really important to note that heart failure, the only cure for heart failure is a heart transplant. And so this is something that families face and survivors of childhood cancer face. And you know, I think the major problem and the driving force behind our research is that we really want to tackle this problem of whether we can reduce this burden of cardiovascular disease in cancer survivors.
Yeah, I remember Dave 8 years ago scribbling on a whiteboard the beginnings of our research. And it's true that from little things, big things grow. We have a very large team, from scientists to medical students, PhD students, scientists, professors of oncology and cardiology, and now we have a national program across 13 institutes, and we're really looking to tackle cardiovascular disease at a big scale. This year we're opening 3 cardio-oncology clinics nationally. They're the first of their kind in Australia, and they will seek to understand the genetics predisposition to heart toxicity from chemotherapy. We're also looking to see with novel imaging techniques whether we can pick up heart failure earlier, and as Dave will go into in a bit more detail, looking to see if we can find drugs that protect the heart from these complications.
Yeah, so you know, the key driver for us is that we want to know which patients are going to be sensitive, and with that we use the sort of advanced genomics that you've heard described by Seb and Catherine. And the other driver is to whether we can come up with new medicines that protect the heart. And one of the strengths of MCRI is the stem cell medicine program, and we can take patient-specific cells and we can turn them into stem cells, and then we can turn them into these mini heart tissues that you can see here. So this mini heart tissue, this contractile, is exactly the same as the child's heart, and it means that we can then look at see how they respond to drugs. So we have all sorts of genetic tricks we can do, and you can see we can look right inside these cells and say, work out why they're sensitive, and then we can look for things that might protect them and protect them against heart damage from their chemotherapy. And so again, as you mentioned, Rachel, from little things, big things grow, and this was an MCRI seed fund program where we used this pipeline to try and discover new drugs. So we started off with thousands of drugs and tested them against these stem cells in the dish, and then we looked to improve those, so that we're about to hundreds of drugs there, and we try and improve those. And then the next step is we take 20 or so into the mini hearts and really study them in detail. And now we're at the stage where we're looking at moving them into animal models as a precursor to moving them straight into the clinic and providing oncologists like yourself a treatment option to protect the patient's heart. So I guess, I'm hoping that would help you down in the clinic, Rachel.
Yeah, so certainly 70% of the patients that I treat are exposed to cardiac toxic medications. So knowing who would be at risk of having cardiac complications would be really helpful, and also being able to give them drugs to protect the heart would be exceptional. I mean, ultimately our research, Dave, is to try and not have the cardiovascular complications of cancer therapy, to try and ultimately reduce the burden on cancer survivors so that there's really no cost of cure, but rather that there's just a cure of cancer.
And now we're going to hear from Tyler, who when he was 15 had heart failure and received a heart transplant.
When I was 15, I had a heart transplant. It wasn't known that I had cardiomyopathy until I got to the hospital, but I spent probably 6 months quite ill. And I also had lymphoma and had chemotherapy. Yeah, by the time I was diagnosed, it was almost too late. But I was fortunate enough to get a heart transplant, and that was 11 years ago now, and been doing pretty well. That's inspired me to be a nurse. Lucky enough that I get to live a relatively normal life, and I'm looking forward to what technologies are going to come about in the future with disease modelling, with stem cells. Yeah, it's pretty exciting to see what's going to be coming in the next 10 years or so. And I want to thank the Murdoch Children's Research Institute for all the work they're doing, and one day we can get to the point where those who have heart failure can not worry as much and live their normal lives.